licensed to provide the blood to the patients. The blood safety has gained a special significance in the last couple of decades, especially after the introduction of the HIV infection in the list of the blood transmissible infections. The blood is nowadays much safer than what it was before in the developed world. As you can see that with the introduction of the voluntary blood donors in 1970 in the Western world, and then with the introduction of the HBsAg testing, then AIDS scenario came in 1980, introduction of the HIV testing for serology in 85, and then testing for the core antibodies as a surrogate marker for hepatitis C, and then the incorporation of the hepatitis C testing in 2000, and now the NAT testing in 2000, and now the viral inactivation methods have improved the blood safety considerably. And you can see that the transmission of the HIV infection in the developed world is 1 in 2 million. The possibility of getting HCV in the developed world is 1 in 1.5 million, and hepatitis B to the tune of 1 in 3 lakhs. But the challenges in India are that the blood transfusion is mainly a hospital-based transfusion service. We have roughly around 2,609 blood banks, and the blood banks are governed by the various controls. There's a wide gap between the demand and supply. We anticipate that we require almost 10 million units of blood, but we are collecting around 8 million units of blood. Here I give an example of the United States. United States, with a population of 350 million, collect around 16 million units of the blood. We, a population of 1.2 billion, are telling that we need roughly around 10 million units of blood. I think this is an underestimation. There, along with a huge population of 1.2 billion, the God has also given us a high disease burden, which is roughly around 2.5 million of HIV, 15 million HCV, and 43 million of HPV infection. There is a very little concept of a regular repeat voluntary blood donation. The testing technology, it is not only the testing for screening for the viral infections, even most of the times I do find that people come to me, once we do the health checkup, we give the blood group B, they come to me, doctor, you have given us a wrong blood group, my blood group is A. And then I have to retest it, and I tell them, yes, the blood group, what I have given to you is the right, because blood group is one which cannot change. So, blood banking laboratory cannot do the wrong things. So, anything wrong in the blood bank can result in the disaster. So, there is a need to have a good quality assurance program in the transfusion services. The low blood components, as against 100% of the blood being used as the components, in this country we use hardly 30% of the blood as components. We have a policy in place, but only, unfortunately, it's on the papers. The lack of trained persons, there's no hemovigilance program, and there's a need to change the mindset of the people. The blood safety revolves around 3 things. The safe blood donor, the safe blood transfusion practices, and the appropriate or the rational use of the blood. The safe blood donor is a pivot for a safe blood supply. A voluntary, non-remunerated donor is a safe blood donor. But unfortunately, only as per the National AIDS Control Organization, 69% of the person are voluntary blood donors. And that too, a one-time voluntary blood donor. There's a little concept, as I said, of a regular, repeat, voluntary blood donors, which is a hallmark for the safe blood donation program. In contrast to this, see, Malaysia from 50% in 2002 have achieved 98% of voluntary blood program now in 2005, and now they have gone to 100% voluntary blood donation. There are already 62 countries in the globe which have almost 100% of voluntary blood donations. So when India has a challenge in itself, we need to modify and strengthen our voluntary blood donation in order to have the safe blood for our patients. The safer transfusion practices, we need not only the voluntary blood donors, but we need to have the appropriate donor selection and pre-test counseling, appropriate blood collection, blood grouping, as I was saying, and antibody screening for all the donors. Infectious marker screening, both by serology and by the nucleic acid testing, bacterial detection, and lastly, we may have to go for the pathogen inactivation. The donor screening by a trained medical staff plays an important role in the provision of a safe blood to our patients. There is a need to have a good medical history questionnaire because this plays a maybe the test may at times not be that right, but in case we have taken the history of hepatitis B, hepatitis C, high risk behaviors, and we have deferred the donors, that can solve the problem of blood safety to a great extent. The demographic information, identifying the high risk behavior, physical examination, simple tests like hemoglobin estimations, the pre-test counseling, essential for part of the donor selection. The high-risk donors need to be identified, deferred from donating blood, and low-risk donors are actively educated, motivated to donate blood regularly. Despite a good technique, one cannot ensure a sterile venipuncture. So what has been done? Now we need to have the first couple of ml of the blood needs to be taken separately so that we can have a sterile blood in the real container. But the provision of such bags in the blood bags, only few of the centers do have it. As I mentioned, that the blood banks are governed by the Drug and Cosmetic Act, and under the provision of the Act, we need to screen the blood for HIV, hepatitis B surface antigen, hepatitis C, antibodies, malaria, and syphilis. And they are all serological tests. And if you see, the serological prevalence of HIV in normal population is 0.36%, and seroprevalence of HCV roughly around 0.9%, and hepatitis B 2.5 to 4%. But you see in the donors, this is almost the same. So our donors and the general population, the prevalence of these infections is by and large the same. See, in South Africa, we have a prevalence of HIV in the normal population is roughly to the tune of 10%. But in the blood donors, it is 0.1% because they have regular, repeat, voluntary blood donors. The same thing in United States, the prevalence of hepatitis C infection is to the tune of 1.5 to 2%. But in the blood donors, it is 0.01%. So this is what counts in the provision of the safe blood to the patients. The residual risk of TTI after screening, the residual risk of transmission infection for HIV may be even 2% or even more. This has been highlighted because of the failure to test, human errors, false negatives, or window period donation. This is more of a problem in this country. Despite the progressive improvement, there is still a concern about the residual risk because the current challenges include balancing the goal of zero risk with the economical realities. Now see, the tests what we do or the immunoassays, they are directed for the virus-induced antibodies or the antigens and not in the virus itself. So the greatest threat is donating by seronegative donors during the window period donation. So the window period donations, false negatives, the chronic carrier states, and atypical genetic variants of the viruses or even laboratory errors can result what we call in the false negative results. Now see, this slide gives you the window period. The window period for hepatitis C, serological window period is roughly around 58.3 days, HIV 21 days, and hepatitis B roughly around 45 days. And if we do a combo test, that is an antigen antibody test, it has been reduced to 13 days, 15 days, and 38 days. This is a big problem in India. Now see, the main concern for India, a few of the studies from India that hepatitis B, even if you do a fourth generation, that you will miss out most of these infections, and that will result in infection to our patients. And now with the introduction of the NAT, this has again been reduced to HCV if we do a mini pool 7.4 days, HIV 9 days if we do a pool of 8, and 6 16, and if we do HPV, it is again 38.3 days. But if you do an individual NAT testing, 4.9 days, 5.6 days, and now with the Ultrio Plus, we can reduce it further for hepatitis B to 15 days, thus improving the blood safety considerably. So closing the gap, there's a need to have the implementation of the two tests to narrow the gap, combining one or two assays, or increase what we call the percentage of the voluntary blood donors. The NAT test, the nucleic acid testing, is now routinely being performed in most of the developed countries, has been made mandatory, and it has decreased the TTI risk after the NAT has been substantial. The advantages of the NAT tests: detects the level of the viral RNA and DNA, highly sensitive and specific for the viral nucleic acid, provides an additional layer of the safety, detects infection earlier than other screening methods, has the ability to detect the viral mutants and occult infections. Now this slide, you can see, as I have already mentioned, that for hepatitis C from 58 days, now with the latest NAT you can reduce to 3 days. For HBV, for Hep C, this is for HIV, for hepatitis C from 58 days to 3 days, and for HBV, now with the Ultrio Plus, you can reduce it to almost 14 to 15 days. The NAT in the Western world, as I mentioned earlier, has made the blood as safe as possible. The possibility of transmission of hepatitis B infection is 1 in 3 lakhs. HIV and Hep C almost to 2 million and 1.5 millions. In Asia, it has been seen that the viral load for our infections, in one of the studies, the results of 143 in the Southeast Asia, 70.7% of these would be missed because of the pool of 6, and 87.5% of the pools in the term, assuming the sensitivity of 5 international units per ml. Because viral load, what we have found, this we have found in our study also, that the viral load of most of these donors is very low. And if we do a pool of 6 or even 4, we will miss up this infection. So in case we have to go for a testing in our blood donors, it is always advisable that we go for an individual donor testing rather going for a mini pool testing. The Indian, what we found, we did the first multicentric study in the country, where we found at a yield of roughly around 1 in 1500. And after that, now see, another study which was conducted at the Loynes Blood Bank, they found as yield of 1 in 2000, and another study which is in the Karnataka, because they are doing in all the medical colleges, they found a yield of 1 in 276, which is alarming. And now see, the Sain et al. In the AFTC, he has conducted a study, he found the yield for 1 in 248. And so he conclusion is that if we have 8 million units of the blood, we will possibly be interdicting almost 34,274 NAT yields. And in case we have the 3 units of blood made out of it, that will result so much of infection into the patients. Kavita Chatterjee from AIIMS, and he found a yield of 1 in 2007. With Ultrio Plus, she got a yield of 1505. But for the hepatitis B, you can see that the yield of 1 in 1204. So conclusion is that with the individual donor testing, what we did for hepatitis C, we had a yield of 7 yields, but what we found, the viral load was too low. But we found a lot of false positivity with the serological tests. We found 24 yields till now, but what we found that the yields, the occult hepatitis, because we are screening the blood also for the hepatitis 4 antibodies. 9% of our people are positive for 4 antibodies, negative for surface antigen, again negative for the NAT. So we are thinking, should we do away with the core antibodies? Because this being followed in the United States, it's very easy to start the test and very difficult then to do away with the test. Now you can see, this is a slide which can show you that we have found already tested over 141,000, while we found total yield of the NAT was 29, HBsAg negative, core antibody active 15, that is an occult hepatitis B, surface antigen negative, core reactive, core non-reactive, but 14 window period NATs, for that was the actual NAT yield. Well, we tried whether we have HIV-2 infection. We screened roughly around 204,000 donors, and we found none of the donors had HIV-2 in our population. What we see in the United States? Now see, the yield is for HIV, almost 1 in 43, it is almost 1 in 4 millions. For Australia, 1, it is 0, almost negligible. Germany, 1 in 1 million, and Japan, 1 in 1 million. Hep C, 1 in 2 million, 1 in 3 million, and then for HBV, it is 1 in 5 lakhs and 1 in 60,000. So in Japan, again an endemic country for hepatitis B infection, but not as endemic as India it is. So with the introduction, why we have to go preferring mini pool, because IDNAT, because high prevalence countries, greater number of the infections, low regularity donors, pooling will result into dilution of the viremic sample, so it is better to have an IDNAT testing. Another thing is the bacterial contamination. This is a very hot topic, especially for the platelets, because we store the platelets at a room temperature. So we have to test them, especially because to test the we have to do the culture. Unfortunately, we do for the quality control. For the red cells, it is not a problem because we are storing the blood at 4 to 8 degrees, but the platelets being stored at 22 plus minus 2 degrees, the possibility of the bacterial contamination is there. You can see the comparison of the residual risk, because the viral infection has become considerably low, but the bacterial infection in the Western world is contamination 1 in 1,000, clinical sepsis 1 in 10,000, and septic fatalities 1 in 1 lakh because of the bacterial contamination of the platelets. Now there are emerging viruses, a big list of these viruses which can be transmitted through blood, and so the people have started going for what we call pathogen inactivation. Pathogen inactivation is the method of treating blood products that inactivate the existing or unknown pathogens that may be present in the blood components. There are various methods: solvent detergent method, Mirozole method. Well, one pathogen inactivation costs almost to the tune of $100. Appropriate use of the blood. The blood is not to be considered as a tonic. There are inherent risks associated with it. So every clinician needs to take an informal consent from their patient. They need to inform the patient that during his stay in the hospital, there is a possibility that he or she may need the transfusion of the blood. And they have to tell him what type of the blood they are going to receive. Whether it is the NAT tested blood, whether it's a serologically tested blood, what are the possibility of getting infection, and they have to document it. This is once we were talking about, are we liable for the litigations? If you have documented, if you have taken the informal consent, no. But if you have not told the patients, you are liable. Because you cannot. I was in one of the meetings, the health secretary, government of India told me, Dr. Makroo, you can afford to do it in Apollo Hospital, we don't have money. I asked the health secretary, well, you don't have the money, but at least you can tell the patient that this blood is not tested for this. I will show you, sir, he will sell his utensils, but he will like to have the tested blood for his patient. And that is the scenario. See, we are all telling that the Delhi Jal Board water is very good, but still we have the RO and AquaGuard at home. Why? So this is what we need in case we need to have the blood safety. Type and screen. Well, primarily all the patients need to be screened for immune antibodies before, because unfortunately very few blood centers do for it. Because it is not only screening for hepatitis B, C and HIV. We need to screen for these antibodies so that the patient does not get immunized. Fresh blood. Most of the clinicians are crying for fresh blood. There is nothing like fresh blood in the entity of transfusion medicine today. And then educate the use of the blood components. Leukoreduction, aphasis blood components. Giriji is just knocking at my mic, so I will take 1 to 2 minutes. The leukoreduction. The leukoreduction is fast taken up in the Western world, but Asian countries are still lacking behind. And well, I have already talked about it. This is what we have the informal consent back home in our hospitals. And the road ahead, the commitment of the blood community to provide the safe blood, active involvement of the health economics, keeping in mind that good quality costs. Good quality costs, but poor quality costs more. Because if you have given an infected blood, it can make your sleepless nights. You can go home, you will always think, I have done something wrong. And if you are taken in the court of law, you are liable. And I tell you, this basically once it was debated, what should we do? I think we need to keep our face tight. Because once we go, everybody keeps on talking as oh, this has been wrong. Well, we are living all in the same atmosphere. So we have to see that what is best for our scenario. I stop here because I know it.